Hello and welcome to the Venous and Lymphatic Forum. We are broadcasting live from the DeBakey Cardiovascular Live studios at Houston Methodist Hospital in Houston, Texas. I am Ulises Baltazar, I am your host, and today we are going to have the pleasure of sharing the screen with a colleague. She is Dr. Jenny Petkova. She is the assistant professor of hematology here at Methodist Hospital and has vast experience in anticoagulation. But before we jump into the topic and the discussion, let me remind you that if at any time you have any questions, comments, or anything like that, you can reach us through this form, these websites that you can post your questions, and we are going to do the best we can to answer accurately. So please let us know what you think and if there is any questions through these platforms. Okay, so now before we jump into the topic that was posted today, I'd like to talk to Dr. Petkova a little bit because she has a very interesting story how she got to the Methodist Hospital and her experience in the medical field, because I believe this is going to give tremendous value to the presentation she will share with us today. So welcome back. Thank you here. Thank you for being us with here in the studio. So you were sharing earlier a little bit about your story. How did you get to the Methodist Hospital? So tell us a little bit about you.
Well, I moved here a little bit less than 2 years ago. Previously, I worked at the Christiana Hospital in Delaware. It is a state. Yeah, some people don't know that. And I was recruited specifically to Methodist to do benign hematology, which includes clotting and bleeding disorders, autoimmune diseases of the blood, and thrombotic microangiopathy. I do have a little bit of background in platelet signaling pathways as far as bench research, and we do have an ongoing registry on TMAs here at Methodist. So if somebody has a patient with thrombotic microangiopathy, we'll be happy to work with you and hopefully recruit that patient.
Excellent.
I trained, did my internal medicine residency in Evanston, in Chicago, and then I did my fellowships in the Medical Center of Wisconsin, Medical College of Wisconsin, and the Blood Center of Wisconsin. So that's pretty much where I come from.
Well, that's phenomenal. It's a well-rounded experience that obviously give you the advantage that you have in this field. So today's topic was chosen because we as a vascular surgeons, many times we need to anticoagulate our patients, and nowadays with all the diversity or alternatives that we have, it's difficult to find the proper anticoagulant if we don't know the background of this. For all of you that are watching this broadcast abroad, outside of the United States, in the United States, the training of hematology is heavily combined with oncology. So some of the specialists like more about oncology, some others hematology. So it's very important who are you going to discuss your patients with, because if they are leaning more towards oncology, they might not be as updated in the hematology side. So we have a tremendous blessing that Dr. Petkova is here with us to share her experience. So Jenny, so the stage is yours.
Thank you, Dr. Baltazar. So I kind of try to expand a little bit the topic to the use of direct oral anticoagulants for deep venous thrombosis. And I'm going to start my presentation today with a brief clinical case. So this is a 36-year-old woman who went to her primary care physician's office complaining of right leg swelling for the last couple of days. She had no significant prior medical history. Her only medication was her oral contraceptive. Her physical exam revealed mild swelling of the right leg and mild calf tenderness. She was then sent to the emergency room where her vitals and CBC were remarkable. BMP, however, showed glucose level of 318. The ultrasound of her lower extremities showed acute complete thrombosis of the right superficial femoral vein, and so she was given a dose of therapeutic enoxaparin in the emergency room and admitted for further care. Now, in the hospital, obviously the first physician that saw her was the hospitalist who admitted her. He simply continued her low molecular heparin and ordered a CT chest to rule out a PE and an echocardiogram in case there was right-sided heart strain. He also consulted vascular surgery for possible thrombolysis or thrombectomy and ordered thrombophilia panel and consulted hematology for thrombophilia evaluation. He also consulted endocrinology for evaluation and management of her newly diagnosed diabetes and discontinued her oral contraception therapy, feeling that this was the cause for her thrombosis. And so what happened the next day? The vascular surgeon obviously saw the patient and examined her. Her swelling was much improved. She had no complaints. So he actually recommended against any kind of procedures and recommended the patient be started on oral anticoagulation. The hematologist also saw the patient, and because we don't do procedures, we talk a little bit more. We established that the patient has actually been fairly inactive for the last 6 months prior to diagnosis due to the COVID pandemic and the need for social isolation. She has gained 50 pounds during that period too. She actually smoked cigarettes, again due to the stress associated with COVID-19. She complained of frequent urination for the last 3 weeks prior to her admission, had history of heavy menstrual period and iron deficiency anemia, for which she had required parenteral iron, and I had 3 healthy children of 3 uncomplicated pregnancies. None of her family members have ever had a clotting event. So since I was the hematologist, I can say that I recommended switching the patient to apixaban of all oral anticoagulants. Promised to review the thrombophilia workup, but I did not feel that this would change her management, at least not at this point, and scheduled to see her in about 3 months. I also encouraged her that she can continue taking her OCP while she's on anticoagulation. So for the next few minutes, I'll try to convince you that these recommendations are actually based on data. And I would like to start with a very brief overview of pathophysiology of venous thrombosis. Obviously, we still talk about the Virchow's triad even nowadays, and you have stasis, vessel wall injury, and hypocoagulability interacting, so you can have thrombosis complication. And as you can see, stasis can be due to immobility, as in our patient, though can be also caused by polycythemia and increased blood viscosity. When we talk about vessel wall injury, this is a fairly interesting topic because both smoking and hypertension, especially uncontrolled hypertension, can damage the vessel wall. More often than not, though, we see this in patients with trauma, after surgery, or after placing of indwelling catheters. There is also a very interesting there are very interesting multiple publications on how COVID-19 can cause endotheliopathy and endotheliitis and increase the risk of thrombosis that way. Finally, hypocoagulability, which is where most of our efforts usually focus when we see patients, and that could be hereditary thrombophilia, such as protein CNS deficiency or antithrombin deficiency, factor V Leiden or prothrombin gene mutation. But more often, these are acquired thrombophilias or acquired hypocoagulable states, including malignancy or chemotherapy for it, pregnancy, hormonal therapy, obesity, extreme exercise and volume depletion have been identified also as risk factors. Antiphospholipid syndrome and heparin-induced thrombocytopenia are the most common diseases associated with thrombosis as well. So as a hematologist, I had to remind myself which are the deep venous veins of the lower extremity and which are the proximal and the distal ones. As you can see, about 70 to 80% of symptomatic DVTs involve the proximal veins of the legs. If you do CT, or in this case the study was perfusion lung scans in patients who have DVTs without any symptoms of PE, about 40 to 50% may have evidence of embolic complications as well. So that's not a trivial number. About 50% of the patients also, if left untreated, will develop symptomatic PE within 3 months of diagnosis. So as far as distal DVTs, they have significantly lower risk of embolization, about 4 to 10% of the times. About 1/4 or to 1/3 of all symptomatic isolated distal DVTs will extend to involve the proximal veins if not treated, and hence in 2016 the ACCP guidelines recommended that we consider anticoagulation for these patients as long as their bleeding risk is low. Now this was maybe published a month before the Cactus trial was published, which showed that low molecular heparin, in this case nadroparin, because the study was done in France and Switzerland, so that's what they used there, but was not superior to placebo in reducing the risk of proximal extension or venous thromboembolic events in patients with distal DVTs. So the next ACCP guidelines, which are anticipated later this year, hopefully will comment on that. Upper extremity thrombosis is extremely rare outside of patients who have indwelling catheters or malignancy. Primary DVT of the upper extremity accounts for about 10 to 20% of these cases, and this is usually in very athletic, usually male individuals, due to hypertrophy of the scalene muscle, which compresses the subclavian vein against the clavicle. PE is also not particularly common in this patient population, about 6% of the time. So this is from the most recent guidelines from the American Society of Hematology. How they look at DVT management is based on a timeline starting with diagnosis. The first 5 to 21 days after diagnosis they call initial management. Then they have primary treatment, which is the time when we anticoagulate patients, and this is usually 3 to 6 months. And that at that junction we need to decide if we should stop anticoagulation or we should continue for secondary prevention, and at what dose. So the current hematology recommendation, again, this is ASH, so take it with a grain of salt. We're not vascular surgeons, we might be a bit biased. And this is a combined slide on patients with pulmonary emboli and with DVT. And as you can see here, in patients with DVT specifically, they recommend that only patients with limb-threatening DVT are considered for thrombolysis, while everybody else, they recommend simply starting on anticoagulation, and some of the time we can even consider just discharging the patients from the emergency room without having to admit them. One of the reasons why some people would recommend considering thrombolysis, even though there is no threat to the limb, is to decrease the risk of post-thrombophlebitic syndrome. And this is a significant complications in patients with DVT. As you can see, between 20 to 50% of the patients will have some degree of post-thrombophlebitic symptoms, and severe post-thrombophlebitic syndrome can affect up to 5 to 10% of the patients. These are the risk factors that have been associated with these complications: pre-existing venous insufficiency, obesity, older age, the extent of the DVT, whether it's proximal, whether it's recurrent, if there are persistent symptoms after 1 month, and if there is persistent DVT at 3 to 6 months. And so it's very tempting to consider using thrombolysis as a mode to decrease the risk of post-thrombophlebitic syndrome. However, this has not been readily supported by the existing evidence. So currently this should be reserved for patients who may not have limb-threatening DVT but do have significant risk of post-thrombophlebitic syndrome based on the other risk factors, including the extent of the DVT. So in our patient who had fairly mild symptoms, this was not indicated, as the vascular surgeon stated in their note. So I just want to plug in a brief couple of slides here for inferior vena cava filters, because we do see them not infrequently in patients who may or may not need them, and it's difficult sometimes to remove them, especially if it's been some time since they were placed. And these are currently indicated for patients with acute DVT who cannot tolerate anticoagulation, either because they have active bleeding or they have very high bleeding risk, either due to a recent bleed or due to ischemic stroke or other risk factors. And this is again ASH guidelines from last year that a removable filter should be used, and then it should be removed once anticoagulation is a possibility. So why is that? So this is a very old study from the 90s, and it was they had another update in about 2008, I want to say. And as you can see, the filters are an interesting thing. They do prevent, as you can see here on the first graph, they do decrease the risk of PE, so they do prevent the development of PE, but this is at the expense of increased risk of recurrent or progressive DVTs. And if you see, the overall incidence of VTE is not different between the groups. There is a little bit more colorful data. This is from Johns Hopkins from quite a few years ago as well, which compared the different types of IVC filter used at that time versus anticoagulation. And anticoagulation is denoted here with this light blue dot. I don't know how well you can see it, but that blue dot here. And they compared the risk of recurrent DVT and the risk of PE. As you can see here, the risk of PE was decreased by some filters, but overall compared to anticoagulation, there was no significant benefit. So if the patient can be anticoagulated, we should consider that. And this is the risk of DVT after placement of IVC filter, again compared to anticoagulation. And depending on which device is used, there is increased risk of DVT with pretty much all of them. So they're not, the complications with IVC filters are not particularly common, but they're not particularly rare either. They can migrate, they can tilt, they can open incompletely, they can be placed in the wrong location, which is rare. They can fracture, and struts from them have been identified on X-rays in many different situations. Luckily, vena cava perforations are extremely rare. Vena cava thrombosis is actually fairly common, as you can see, up to 30% in certain studies, about 10% with the contemporary filters. I mentioned recurrent DVTs and the increased risk of post-thrombotic syndrome. So that's pretty much all I wanted to say about the immediate diagnostic period, and we're going to continue with primary treatment. And this is the time when we have to decide what anticoagulant we should use. And I wanted to talk very briefly about the so-called coagulation cascade, and I termed it so-called because it is not really a cascade, it's actually a pathway. As you can see, there are arrows going up and down and back, etc. This is a simplified view of all of that, and it doesn't occur randomly in the blood, it actually occurs on the surface of the endothelium. So there is a significant cellular component of that, which is not pertinent to the anticoagulants, and so I'm not going to spend time on it. This is again the same anticoagulation cascade, indicating which are the naturally occurring anticoagulants. And as you can see here, we have antithrombin, which inhibits both thrombin, as the name implies, and 10A activated. And we have protein CNS, which inhibit factor VIII and factor V. So I'm going to talk a little bit about the individual anticoagulants that we use, and what is their mechanism, how they can be used, and what is their reversal agents. So heparins were the oldest ones that were developed back in the beginning of the 20th century, discovered in a lab by a surgeon and a medical student who were trying to identify clotting substance to prevent bleeding during surgery. They're working with canine livers, and hence the name heparin, from heper, liver in Latin. Later down the road, low molecular heparins and fondaparinux were developed. They are parts of the unfortunate molecule, and so I'm going to talk about all of them together. These are indirect thrombin and 10A inhibitors. To be active, they need to bind antithrombin and this converts it from a very slow to a rapid inactivator of thrombin and factor Xa. And so this is a cartoon of how they work. As you can see, the unfractionated heparins here have these long molecules which are able to bind both antithrombin, and that would allow it to inactivate 10A, but also they can bind simultaneously antithrombin and thrombin, and this would result in thrombin inactivation as well. Now, the low molecular heparins and fondaparinux, which here is identified by this 5 number there, cannot really bind both thrombin and antithrombin at the same time. So they can only bind antithrombin, which results in activation of antithrombin, in activation of 10A, but they do not have a significant effect on thrombin. And this results in how we monitor them. As you can see here, the inactivated factors are 10A and thrombin. However, monitoring is a little bit different. You have either PTT or anti-10A levels when it comes to unfractionated heparin, while low molecular heparins need to be monitored with anti-10A if we have to. And then as far as reversal, you can use protamine for unfractionated heparin. It doesn't inactivate very efficiently the low molecular heparins, and it has no activity against fondaparinux. In essence, there is no reversal agent for fondaparinux. So warfarin, which is probably the drug that we've been using most extensively for a very long period of time, was discovered in the 1950s, and the name is from Wisconsin Alumni Research Foundation, since it was discovered in Wisconsin after a farmer noticed that when eating certain molded hay, his cows developed bleeding and died. So he put the cow on the truck and the hay and took it to Madison, and they discovered warfarin. Initially, it was developed really for rodenticide, and then they figured that it actually has very many beneficial effects when it comes to humans, so it was developed as a drug. It works by inhibiting the vitamin K-dependent gamma carboxylation of coagulation factors 2, 7, 9, and 10, as well as protein CNS. This results in the synthesis of immunologically detectable but biologically inactive forms of these anticoagulation proteins. So although the molecule may be identifiable in the bloodstream, it cannot be activated and hence cannot trigger or participate in anticoagulation. And yes, protein CNS are also dependent on vitamin K, and their levels will be decreased as well. So this is how warfarin works. You can see 2, 7, 9, and 10 are the ones that will be decreased. Monitoring relies on the INR, and INR is just a way to modify a PT, prothrombin time, because historically the reagents used were very different between the different labs, and the PT measured in different labs was significantly variable. So the INR was a way to normalize that to a specific reagent. And so the reversal can be done with vitamin K if there is no urgency, or if there is an emergency that either because of bleeding or a surgical procedure needs to be done, then we need to use a 4-component concentrate such as Concentra. Okay? And so the point here is that plasma can be used, but it takes significantly longer compared to the PCCs, and we should prefer using PCC if we have them available. Finally, direct oral anticoagulants. Obviously, these are fairly new. They were called novel oral anticoagulants, or NOACs. The most recent one was approved in 2014, so I think they're not quite novel anymore, and there are a couple of new options that are in clinical trials, so maybe we should just stick with direct oral anticoagulants to underline their differences from warfarin. So they inhibit their targets directly. There is no vitamin K inhibition, and there is no synthesis that is different or factors that are not activatable. So dabigatran was the first one to be approved, and it's a direct thrombin inhibitor with the trade name Pradaxa. Well, there's a few factor Xa inhibitors on the market. The first one to be approved was rivaroxaban, followed closely by apixaban, so Xarelto and Eliquis. Edoxaban is rarely used nowadays in the US, but it is used in other jurisdictions quite a bit, and you'll still see a lot of research data coming on with that drug. Betrixaban is approved for prophylaxis. Unfortunately, it's not available in the US. So I'm not going to talk a lot about that particular drug. So this is where they work. You can see that 10A is inactivated, or thrombin will be inactivated. Monitoring for the dabigatran would be by using either PTT or better thrombin time. There is a specific assay for thrombin time that is very sensitive and can determine the degree of anticoagulation as well. This is a chromogenic assay, which is not readily available everywhere. So you need to know what your lab has. And then the anti-10 level should be used for the different 10A inhibitors. Our lab does both assays 24/7, so they're very easy to obtain, at least here at the medical district. Reversal for the dabigatran, there is idurosizumab with the trade name of Praxbind, and for the 10A inhibitors, you can use Indaxinet. In jurisdictions where that's not available, you can still use the full component PCCs, though this will be based on preclinical data, and it's not clear if there is any benefit from the PCC itself, or the drug's short half-lives are the ones that actually help in those situations. So what are the advantages of the direct oral anticoagulants over warfarin? Well, obviously there is no dietary restriction. There is no need for monitoring of the INRs. There is also lower bleeding risk, and the next few slides will show that. And there is a significantly easier perioperative management as well, because there is no need for Lovenox or for low molecular heparin bridging. So as I promised, a little bit of a composite slide. I don't know how well you can see it, but these are a few of the trials that got all these DOACs approved, and they are all compared to warfarin in these trials. There were very different designs, with some of them trying to prove non-inferiority, some of them having also provisions for superiority, but either way, all of them showed either non-inferiority or superiority to warfarin as far as prevention of recurrent VTE goes, and they had lower bleeding risks. Now, most of the studies were done in patients with VTE and not necessarily DVT. Rivaroxaban was the only one who had a separate studies on DVT versus PE, so we can kind of extrapolate from those studies. So this is a composite slide again on how the different anticoagulants compare to warfarin, and as you can see, they definitely prevent recurrent VTEs as well, if not better, than warfarin. However, their bleeding risks are significantly lower, with the major exception here of the dabigatran, which may have a little bit of a higher risk. So based on that, for the most part, nowadays we rarely use warfarin outside of certain very specific applications. So this is another composite slide on the differences between the different DOACs, and as you can see, the major differences are in their metabolism. Apixaban has the lowest degree of renal excretion, while the dabigatran has the highest degree. Considering that a lot of our patients are a little bit older and may have issues with their kidney excretion, that may make a difference as to deciding which drug to use. There is also differences in how often they are given, how their absorption is, etc., etc. Now, this is another slide which kind of speaks to the same thing, but this time includes other anticoagulants as well. And here in red, you can notice the two situations in which we should not consider DOACs. And the first one is obviously pregnancy. There is no clinical data on the use of DOACs in pregnancy, while DVTs are not uncommon in that patient population. There is rat data for rivaroxaban that it can be associated with increased risk of embryopathies. There is no data on the others, even in animal models. So currently, we should still stick with low molecular heparins in those patients. And then the other group of patients are patients who have antiphospholipid syndrome. And for those, warfarin should be preferred. And this is based on two different trials indicating that patients who are managed on rivaroxaban in both trials have increased risk of thrombosis compared to patients who are on warfarin. And this was specifically true for patients who are higher risk for recurrence or have arterial thrombotic events. For the vast majority of other patients, even patients with cancer-associated thrombosis, we can consider a DOAC. Now, there is a slight difference in jurisdiction based on where you are, as far as end-stage renal disease and patients with liver disease are concerned, because in certain jurisdictions, the DOACs are not approved for those indications, while in the US, they are approved for patients with AFib, and we often consider them clinically for patients with DVTs as well. So there might be a bit of a difference that way. So what is the role of our knowledge if the patient has hereditary thrombophilia when deciding what anticoagulant to use? So this is a slide on hereditary thrombophilia altogether. You can see their incidence is extremely low when it comes to antithrombin, protein C, and protein S deficiencies, while factor V Leiden and prothrombin gene mutation are fairly common in their heterozygous states, especially in individuals of European descent. They are significantly less common in people of African American descent, and in patients from Asian or Latin American descent, we really don't have any numbers, but they seem to be lower. Now, the risk of VTE in patients with thrombophilia is also not the same. As you can see here, the relative risk is significantly higher for patients who have protein CNS or antithrombin deficiency, while the risk in patients with factor V Leiden and prothrombin gene mutation is a little bit higher in the homozygous state, but fairly low in the heterozygous state. And so this is a meta-analysis of the original studies of the DOACs, specifically looking at patients who had thrombophilias. And there were few patients in each trial, as you can see, a few hundred patients in each trial. And there was no difference between the DOACs and the warfarin group. The trend was in favor of the DOACs, even in these patients. And so when deciding what anticoagulant to use, we don't need to wait for the results of the thrombophilia workup, and we can simply start the patient on a DOAC. There are a few pitfalls of thrombophilia testing, especially in the acute DVT period. Obviously, the genotype-based test, as well as cardiolipins and beta-2 glycoproteins, can still be performed at that time, but for the rest, they can be influenced by the presence of acute thrombosis, because that will result in consumption, or anticoagulation therapy, which would often skew the lupus anticoagulant testing. In addition, if you have very high factor VIII levels, which is not uncommon after thrombosis due to the local inflammation, this can result in spuriously low protein S just due to the testing methodology in the lab. Warfarin may also affect the protein CNS levels, while DOACs can cause spuriously elevated antithrombin levels. So you have to be cautious when interpreting the results of thrombophilia testing, especially if done in the immediate DVT diagnosis period. So this is from a review series from blood from last year, looking at management of thromboembolic risk in patients with hereditary or acquired thrombophilias. And as you can see here, patients with antiphospholipid syndrome, they recommend to use warfarin. Patients with other thrombophilias, however, they recommend using DOACs and management of the patients as if we didn't know that they had thrombophilias. Patients who are high risk but they have never had a thrombotic event should be managed with prophylaxis at high risk periods, and patients with antithrombin deficiency, we can consider antithrombin replacement therapy. But this is really rare, as I showed you on that slide. Another group of patients in which we occasionally avoid DOACs are extremely obese patients. And the current guidelines are from, again, 2016, this time from ISTH, the International Society of Thrombosis and Hemostasis. And they recommend that we don't use DOACs in patients who have BMI more than 40 or weight more than 120 kilos due to lack of data. Well, it's been about 5 years, and this is a review of retrospective data showing that there is no difference between DOACs and warfarin in patients with significantly increased BMI. So we don't really avoid them in somewhat heavier patients as well. Finally, the use of oral contraception or other modes of hormonal contraception. So this is another review of from 2016, which indicated that women who were on contraception at the time of diagnosis or had to start contraception after they were diagnosed did not have increased risk of recurrent VTE while they remained on anticoagulation therapy. If your patient needs to be on contraception and they wish to stop anticoagulation, then you can use progesterone-only hormonal therapy, which is associated with lower risk of VTE, and maybe in certain studies is not associated with risk of VTE at all. And then you need to remember from this study is that abnormal uterine bleeding was more common in patients who are on rivaroxaban compared to warfarin. And so that is a reason to consider a different DOAC in a woman in childbearing age. So how does this apply to our patient so far? So she has proximal DVT, hence she needs anticoagulation. There are no contraindications for anticoagulation. She has history of iron deficiency anemia, but currently her CBC shows normal hemoglobin. She has history of heavy menstrual periods, so as I mentioned, maybe rivaroxaban is not the best option for her. She's not currently pregnant, so we don't need to consider low molecular heparins. She's able to afford a DOAC, which is a major issue in certain jurisdictions, and that's probably the most common reason nowadays to see a patient on warfarin rather than a DOAC. She weighs just shy of the cutoffs, and we already mentioned that even if she was a little bit heavier, this would not be necessarily a contraindication for using a DOAC. We don't have her antiphospholipid testing yet, this is true, but she has no other history of autoimmune diseases, no history of lupus, so the probability that she would have antiphospholipid syndrome is extremely low. So she actually got discharged on apixaban. So what do we do after the first 3 to 6 months of anticoagulation? And this is an interesting area. We need to determine what is the risk of the patient of having a recurrent event and what is their risk of having a bleeding event. And historically, we used to look at crystal balls for that. Now we have predictive scores. They're probably a little bit more accurate than divination, but probably not by much. So again, this is from this review series from last year. As you can see, people who have isolated distal DVT or a VTE which is clearly provoked, let's say by surgery or severe significant immobilization, those people need to stop treatment at around 3 or 6 months based on certain expert opinion. Patients who obviously have ongoing risk factor for thrombosis, such as patients with cancer, should continue anticoagulation until either they are cancer in remission and they are no longer on chemotherapy. And now the interesting group, as you can see here, is the patients who have first unprovoked proximal DVT or PE. And then we look at their bleeding risk. If they have high bleeding risk or they are not willing to continue anticoagulation, then we have to stop anticoagulation, because obviously the patient has to make their own decisions with our help as far as what are the risks and benefits, but still there is a small percentage of patients who would not remain on anticoagulation no matter what we say or how we say it. Patients who have the recurrent events obviously need to remain on anticoagulation too. So this is this last group here. And then this is those that are a little bit more challenging. If they have high probability of recurrent VTE, and that's a good question how we determine that, and they also are willing to continue with anticoagulation, we can continue with anticoagulation without doing any further testing. And then for the patients who are not sure, or we are not sure what is their risk for recurrent thrombosis or for bleeding, we can check additional labs. And these particular experts recommend checking a D-dimer and antiphospholipid testing here and not a diagnosis. And we should continue anticoagulation if their D-dimer is positive or they have antiphospholipid testing positive, obviously. Or if they have negative testing, then you can discontinue. So fairly complex algorithm, I have to admit. And this is because we don't have a clear-cut knowledge as to what is the risk of recurrence in each individual patient. The important thing here is, as you can see, is the unprovoked VTE have higher risk for recurrence compared to the provoked ones. And interestingly enough, women who have VTE due to oral contraception don't have significantly increased risk of thrombosis, a little bit higher than the provoked by surgery, but not very high. So that is not a reason to consider long-term anticoagulation either. So these are a few of the prediction models that I mentioned. The HER2 study, which is probably the oldest, the Vienna prediction score, which is probably the best verified and validated one, and then the DAR score, which is the most recent one, is probably most used nowadays as well. And you can see that they look at the D-dimer, all of them. Some of them look at age, some of them look at gender, and so they're currently not recommended because they're not well validated yet. But in situations in which we're not sure or the patient needs a little bit more clarification, they can still be used. The important thing here is if you're using the HER2 score, you can do D-dimer while the patient is in anticoagulation. While for the other two scoring systems, you need to discontinue anticoagulation and test the D-dimer when the patient is off. So we usually use a period when the patient needs to be off of anticoagulation for a procedure to actually do this testing. After the first 6 months, there might be a possibility to reduce the dose of the anticoagulant. And there are two anticoagulants that have been studied this way, rivaroxaban and apixaban. So the apixaban was the first one to be done, the Amplify Extend study, that showed that compared to placebo, both decreased dose and the regular dose had a significant protective effect while not having significantly increased risk of bleeding. The Einstein choice is probably the more interesting one because it also contained an aspirin arm. So as you can see here, after the 6 months again of anticoagulation, they stratified the patient to low dose rivaroxaban, therapeutic dose rivaroxaban or aspirin, and as you can see, the risk of recurrent thrombosis was significantly higher with aspirin compared to the 2 doses of rivaroxaban, with the bleeding risk not being significantly different. So based on that, we don't currently recommend use of aspirin as a prophylaxis for DVT. If the patient has a different indication for use of aspirin, then we can still use it and maybe discontinue anticoagulation, especially if they have, let's say, cardiac stents, which require antiplatelet therapy. But if we can avoid using aspirin, we should stick with the lower dose of rivaroxaban or apixaban based on these data. So for our patient, she actually did come to see me after about 3 months. And her initial thrombophilia testing showed low protein S and positive lupus anticoagulant. I repeated them at the time I saw her 3 months later, and both were normal, so she did not have any thrombophilia. She discontinued anticoagulation after 6 months of treatment, and based on her own decision, she switched to a different type of contraception, so she doesn't need to worry about recurrent thrombosis. She is currently trying to lose weight, and smoking is next on her agenda. So with that, I'd like to thank you, and I'm happy to take a few questions.
Wow, what a treat we had today. This is a wonderful summary.
Thank you.
Really excellent presentation, Dr. Petkova. Thank you for this wonderful summary. And the numbers that were presented there are very important, especially for our viewers. We have some med students watching, as well as general practitioners all over the world. And this is a tremendous summary because you took basically basic science all the way to clinical science. That is the objective of medicine. You need to learn the molecules, the path, in order to help our patient. So we have few questions that our viewers have posted. Let's see the first one, guys. Do we have let's see, our director, our manager back there? Okay, the first question, how to deal with the theoretic risk on putting a patient on NOAC or Warfarin before ruling out with certitude a malignancy, given that malignancy can exist without another clinical manifestation. So in other words, you have a patient with a DVT or PE and unprovoked, right? And then 6 months later, they find a malignancy.
So this is not unusual. About 5 to 10% of the patients who present with unprovoked thrombosis will be diagnosed with a malignancy within the first year after presentation. And there has been an attempt to do additional testing for these patients in addition to age and gender appropriate cancer screening to make sure they don't have a malignancy. There was a study from a few years ago that looked at doing a CT scan of the abdomen, trying to rule out such a malignancy. It did not increase the diagnosis of malignancy, so that's not currently recommended. The good thing currently is that for patients who have a malignancy, DOACs are a good treatment options compared to low molecular heparins. There have been 4 different trials on all 4 DOACs currently, and the most recent one is from last year, the Caravaggio study that was on the apixaban, and all of them showed that compared to low molecular heparins, DOACs have similar preventive rates and similar bleeding risks, with the exception of rivaroxaban, which resulted with increased GI bleeding risk. So if you do suspect, or if your patient has not had a recent colonoscopy, then it might be reasonable to avoid rivaroxaban, but apixaban is still a good option for those patients. And even with patients with known malignancy and cancer-associated thrombosis, we do recommend DOACs at this point.
Okay, that's complete, right? The answer. Next question, let's see, does NOAC or Warfarin have an effect on endothelial inflammation by blocking certain coagulation factors which may contribute to inflammation?
So this is a very good point, actually, and it's been asked a few times around, again, the COVID pandemic because of the high risk of thrombosis there and related to inflammation, obviously, and endotheliopathy. And the short answer is we don't really know. Warfarin does not seem to be preventive in that situation, and we don't really know if DOACs will play a role. My suspicion is probably not. If you look at the body of literature on heparin in patients with inflammation-related thrombosis, seems that heparin has a very complex effect, which includes not only anticoagulation, but also modification of netosis, modification of recruitment of neutrophils to the endothelial wall, preventive role of the glycocalyx of the endothelium, decreasing platelet activation, and modifying the monocyte cytokine secretion, TFPI secretion, etc. So it has a little bit more pleomorphic pleiotropic effect compared to the DOACs, which are really targeted to specific clotting factors.
Correct. Okay. Next question: to assess D-dimers on anticoagulation or after a discontinuation, do we have to avoid its dosage during menstruations?
I'm not quite sure. I think these are two separate questions. So yes, you can assess D-dimer on anticoagulation if you're using the HER2 scoring system, because that's how this study was done. Alternatively, you need to discontinue anticoagulation for the other two scoring systems. And then if do you need to change dosing during menstruation? No, the short answer is we don't recommend that. We do recommend maybe in women who have heavy periods using apixaban. Again, based on the data from that one study, that rivaroxaban can be associated with increased specifically GU bleeding risk. But no, we should not specifically target different dosing during the menstrual period.
The other question that we were, tossing around earlier before we started the show is, when we have a patient with a dissection, aortic dissection, carotid, whatever, and also has atrial fibrillation, for example, and the patient was on DOACs, Eliquis before the dissection. We normally start Plavix after that to inhibit the platelets and reduce the inflammatory changes in the endothelium. So for long-term management of patients like that have AFib and dissection, another lesion in the endothelium, what is your choice? Is still double anticoagulation, or
oral antiplatelet agent? So this is a little bit of a tricky situation because it depends on the CHADS-2 score as far as the AFib and risk of thrombotic events that way. We don't think of antiplatelet agents as a good preventive strategies for patients with AFib, and so we do recommend that those patients still consider an anticoagulant. And this is usually decided on an individual basis, but it's not a contraindication. There's no absolute contraindication to combine an anticoagulant with an antiplatelet agent. Sure. It increases the risk for bleeding a little bit, but again, you can also use the HAS-BLED score, for instance, and calculate that one to help you manage these patients. We do see a fair number of patients who need to be on anticoagulant for AFib and an antiplatelet agent, maybe because they have a stent, and the vast majority of these patients do well. So I guess in the case with dissection, specifically patients, you can do that.
Couple more questions and we'll be done, but can menstruation modify D-dimers?
Yes, it would increase D-dimer.
Well, there you go, that was straight. You mentioned and talked about the hormone therapy in females that may increase the risk of coagulopathies or clots or DVT or PE. What about in males when they are on testosterone? We have a lot of patients that are taking replacement, and sometimes, I have patients with unprovoked DVTs that come to see us, and we start looking at the history, and the only thing they might have is testosterone.
So I have to admit that this is actually a poorly studied area. And the few studies that have been published have been a bit controversial, contradicting. It seems that the risk of arterial events may be a little bit more significant with testosterone rather than the venous events. I tend to treat these patients as unprovoked as much as I can. These are usually men in they're a little bit more advanced in life, so to speak. And so they might have other risk factors for thrombosis too. Sure. in general, men tend to have higher risk of recurrence compared to women, and I may consider long-term anticoagulation for them anyway, rather than stopping their hormonal manipulation, which is oftentimes very important for them.
Sure. Absolutely. So, you know, one of the numbers you show there is very important. The risk of proximal when the patient has a proximal DVT, that for med students out there, we consider that are above the popliteal vein and higher, distally is not as risky. But when you have a proximal DVT in the lower extremity, the risk of having pulmonary embolism is high, unbelievably high. And many times, like you've seen it, is subclinical. The patient has no symptoms. Nevertheless, the patient showers some thrombi into their lungs. So it's very important to be cognizant of this, because you need to be aggressive in order to try to prevent any further damage, or that PE becomes clinical. You know.
Yeah, no, this is true. Since I'm a bit advanced in life too, I remember times when we used to scan everybody. If they had a DVT, we'd do a CT scan to see if there is a PE as well, mostly because at that time the guidelines were also slightly different as to how we should anticoagulate patients with DVT versus PE. Now, for the last 10 years or so, things have changed and we no longer recommend that, but it's very important to make sure the patient is adequately anticoagulated early on to prevent that. There is also a possibility that the patient will develop a PE the first week or so after diagnosis, even with adequate anticoagulation. These are not considered recurrent events. This is not considered failure of anticoagulation. We just need to be cognizant of that and make the patient aware too.
Correct. All right, last question. I think we have something here. Do you recommend lymphatic circulation assessment in case of DVT? If yes, what test can we use?
So that's a good question, probably for a vascular specialist, and I admit my limitations there. But in general, as hematologists, we don't think of this that way. I understand the importance of vein health when it comes to DVT, and then having alternative circulation, but I'm not sure if this would help us decide on managing these patients any differently. So at least at this time, we don't consider this routinely. Yeah,
the assessment of the lymphatic circulation sometimes is tricky because the tests that we have, the visual tests, are lymphoscintigraphy and lymphoangiography, and they are painful. They are not easy to tolerate, the lymphoangiography especially. So the only reason we as the surgeons try to visualize the lymphatic system is if we are planning to do a procedure, a surgery, a bypass, some sort of alleviating procedure for lymphedema. So it's not a routinely done, no. Now, in latest years, the indocyanine green is being making a lot of noise because it's a relatively painless study that actually can be done in the office. It's not FDA approved. With the fluorescent light, you can see the lymphatics beautifully moving, but right now as a routine with the patients with DVT, do not do any imaging for lymphatics. That is the answer to that particular question from the vascular surgery standpoint of view. All right, well, we ran out of time. We are so grateful to Dr. Petkova for coming today and taught us all these wonderful points in hematology and anticoagulation, especially for surgeons, for medical students that are out there. We thank you for your time. Thank you, Jenny, for coming.
Thank you for having me.
Hope you can stay here. You can come back another time to tell us about another interesting topic. Thank you, everybody. We'll see you the next fourth Wednesday in April. In the meantime, be safe, stay safe, and God bless. Thank you.